over to you.
Thank you very much, Navneet Singh ji. Dear trainees, good morning, warm welcome. Now all the new batch has set in well. It's now almost 6 months. So now we understood the workflow in your respective institution and got into what is oncology and how vast it is. As I always tell you, DNB surgical onco, there are two cases which are make or break cases. One is head and neck oncology, second is breast oncology. Every student will get this in your exam, and without mastering this and without being 100% accurate in this, nobody will actually clear their exams. And as you know, we take help of Dr. Kaustubh every year to span out this detailed head and neck program. Now this would run to almost next 3 months. Every aspect of the head and neck oncology is being covered, taken care by Dr. Kaustubh. And today we have the opening and first talk, that is the basics in oncology by Dr. Shamit Chopra. He is a fellow and visiting assistant professor in the American Head and Neck Society. He is also Head and Neck Center of Excellency Chair and Director of Patel Hospital, Jalandhar. And we start with basics in oncology today. Dr. Shamit, thank you very much for accepting our invitation. And Kaustubh, thank you very, very much for helping us putting it through. So welcome and over to you.
Great. Did the co-moderator want to make any comments, or should I start directly, Dr. Singh?
Yeah, Kaustubh, please welcome to make few comments.
Welcome all the trainees. This is going to be a very strong academic program for next 2 to 3 months. And Dr. Shamit, thank you so much for accepting it. Everyone should know that Shamit is keeping an Indian Society of Thyroid Surgeons conference for at least 2-3 sessions, just because of this schedule which he accepted because of us. So Shamit, thank you so much. Please proceed.
Thank you, sir. Thank you, Dr. Somashekar. And at the outset, I must congratulate your initiative. I think all of us are together or united in believing in the philosophy of surgical education. I hope I'm audible and the slide is visible as well.
Yeah, very clear. Thank you.
Great. So when I was given this initial talk, I expressed my credit to the two moderators as well as Dr. Dushyant, who asked me to speak on this. And of course, as a practicing surgical oncologist for a couple of decades, it gave me the opportunity to go back and see what our students typically face in our exam, as an extension to what Dr. Somashekar was saying. Basics in oncology is an extremely important topic, and I believe it forms a large part of your examination curriculum. On a couple of occasions, I've been an MCH paper setter, but it's great to be affiliated with the National Board of Examinations today. Before we start, of course, I think it's important for the trainees. I think it was mentioned that all of you are at least 6 months into your program, and this might be something that you're already aware of. But we know that the magnitude of cancer in our country really leaves this epidemic to be addressed by all of us. And we see about 10 lakh cases a year in our country, and a figure that all of us think is grossly underreported. However, estimates, however conservative, indicate that 16.5 lakhs will be the approximate increase within about a year, about a decade. And we know that the budget allocation is not adequate. And I'll take the first 7 slides to just give you a perspective, because this is the inaugural talk, and it's important to know how we are placed in the country vis-a-vis management of cancer and how we can add to it. If you look at Globocan data for oral cancer, you know that we get a high age standardized death incidence, and we get 60% cause-specific mortality. Figures to really worry about, but at the same time be adequately focused also in terms of curbing or countering this menace. One slide of data from my state. I chair the IMA Oncology chapter in Punjab. I've done it for the last 8 years now. There's a lot of hyperbole in terms of Punjab being the cancer capital of India, and that's really not true. We know that most of our districts, and here you see the figure on the right, where only 3 districts have an incidence less than the nationwide average. Multiple postulations have been done. The Oncology Committee has done a few studies. And the thing at the bottom is something you can see. The ICMR selected Punjab as one of the first states for developing an atlas of cancer. This was way back in 2012. We were very, very actively affiliated with it, along with some studies, some incident studies. And One sobering feature is what you see just bottom to the red line. 80.3% of groundwater in the Malwa region. Malwa is one of the three regions of Punjab, and that's, as you might be knowing, it's separated by the waters or the rivers that run through it. 80% of groundwater was unsuitable for drinking. Already there's a lot of evidence in terms of, or emerging evidence, or evidence that we should contribute to in terms of pesticides, industrial carcinogens, but again, worth considering as we move forward. In our country, of course, there are multiple challenges in cancer management, and I divided into three. Infrastructure, there is an inadequate number of cancer centers, and the lack of training programs is being addressed every single day. But that being said, we still believe that we are underserved in terms of structured training programs. There is a poor penetration in the periphery of standardized cancer treatments. The cost and the finance schemes, of course, don't help either. So the infrastructure is a big challenge. Look at this graph, and that again makes us extremely concerned about the fact that we only have one oncologist per 1 million population. This is 2018 data. You see right at the end, this is select countries, and you see how much of a gap we need to fill. There's a skewed doctor to patient ratio. The training level is non-homogeneous. We don't have recertification. It behooves all of us to typically stay focused and contemporary, but I think that recertification is the need of the hour. It needs to happen. Site-specific oncology is still nascent. Huge credit to people like Kaustubh and Dr. Somashekar for picking up subspecialty verticals within the wide ambit of surgical oncology. Hopefully, you'll all do it as your career moves forward. And there's a lot of inability to subsidize in our physician factors because there's a very high overhead. Patient and community factors, huge issue. Again, look at all the hyperbole. Look at this advertisement where homeopathy and healthy lifestyle is being touted as a so-called evidence-based management of cancer. And this is something all of us face every day. We get advanced disease at presentation, and this is head and neck only, but most of the rest are essentially things that apply to all cancers in general as we manage these patients. Out-of-pocket expenses, insurance cover, as per one IRDA data, 0.17% of the Indian population is covered by insurance, compared to other so-called developed countries where there's more than 50%. Naturally, that means that the treatment cost has to be borne by the patient. Very sobering data on the left. The spending in a cancer-afflicted home was about 40% more than any other household with similar demographics. Epidemiological, simple observational study, but shows you what kind of problem we face. And about 45% of patients faced, as per socioeconomic data, catastrophic expenditures. 25% patients were pushed below the poverty line. And as you see, the blue circles and the orange circles, in the space of more than a decade, the cost of treatment, and again, this is very vague data, but that being said, it's derived from some publications which shows that on an average, the cost of treatment has risen about 2 to 4 times. If we look at insurance as a solace, it really does not cover it. The reason is that the claims are high. 1 in 5 claims is for young patients. The average amount per policy is low. So we typically, when you see your patients in your clinics and they are not covered by any particular scheme, you ask them to seek critical illness cover, especially for the families of your patients, because once a patient has had cancer, they don't really have an option, but their families, their first degree family members, as well as the people that they know, do have that option. The government has tried hard to grant them that. I think with regard to GDP, it's increased more in the favor of cancer now. This is the last general slide before we move to the core topic. But about 5,000 crores was allocated to strengthen tertiary care facilities, and there's further developments in the National Cancer Control Program where the RCCs as well as government institutions are being given more grants. So it's extremely important to know that the cost of treatment as well as the physician infrastructure and patient factors end up playing a huge roadblock in terms of our challenges for cancer management still. All of us innovate, all of us subsidize in some way or the other. And the best way, of course, is to screen these cancers. There's a lot of screening initiatives that your institutions would be part of. These are a few that we are part of every year. The earlier you detect cancer, the more you can treat it. The cure rates are great, the cost of treatment is less, and everyone wins. Coming to basic oncology, after spending about 5 minutes of the magnitude and the challenges of cancer in our country, this is what I found in your curriculum for all the trainees. In basic oncology, these are the topics that are expected to be covered: etiology and epidemiology, prognosis and natural history, cancer biology, tumor immunology, basic principles of treatment and screening early detection. In about a 40-minute talk, it's difficult to encompass all of them. So we'll talk just about some perspectives as we proceed. So what is a neoplasm? A neoplasm is abnormal growth, which was defined by Willis way back. A malignant neoplasm, in addition, has a propensity for invasion and metastasis also, in addition to all the other factors that typically typify the hallmarks of cancer. The concern about cancers are that they're all heterogeneous, not just the body sites, but the biology, the way they behave, the medicines that they respond to, the surgeries that they respond to, as well as their radio responsiveness is all unpredictable. A lot of them relapse and a lot of them are treatment refractory. Even though there is very elegant data emerging across the world now with regard to predicting the potential responsiveness of tumors, they still remain, for the most part, something in which still some guesstimates are required. So an understanding of tumor biology is essential. So the three things at the bottom are the three topics that we'll be discussing today. We'll talk about the hallmarks of cancer, because unless you understand the biology, you cannot apply that knowledge to the management and the investigations of these patients. We'll just have a few slides on basic principles of surgical oncology vis-a-vis a multidisciplinary perspective. How does a medical and a radiation oncology see surgical oncology vis-a-vis the goals that they need to achieve? We'll talk a little bit about that. And of course, data pertinent to our country as well as worldwide. Whenever we take up a patient for cancer surgery, which you do every day, there are certain perspectives which predict a favorable outcome. Nutrition is one of the most important factors that we face every day in terms of making sure that we are able to give our patients an optimized outcome. So we'll talk about that. Coming to the first topic, the hallmarks of cancer was, and we'll get some a little esoteric, so we'll try to give some instances as we move forward, but the first part of this presentation would be tedious. I'll be glad to share the PDF with the NBMS, and if they feel appropriate, they can share it with all the participants. But broadly speaking, the original hallmarks of cancer were explained by Hanahan and Weinberg in this seminal paper in 2000 in the journal Cell. And essentially, tumors sustain proliferation, they evade tumor suppressors, as we've read about over the last many decades. They activate invasion and metastasis, and we'll talk briefly about the mechanisms without being extremely into molecular biology. Hopefully that should help you as you move forward in your examinations. Replicative immortality, which is one of the hallmarks of cancer, is something that we'll talk about. How does angiogenesis promote the spread of cancer? And how is apoptosis resisted in terms of cascading along with proliferation, invasion, metastasis, immortality of replication, how it moves forward. So in terms of sustaining proliferative signaling, these are the normal mechanisms that you see on the left. There are intracellular, extracellular, and extracellular matrix receptors. Any growth factor comes and joins to a growth factor receptor, as you can see on the left. It activates certain proteins, they go to the nucleus. There's activation of genes that control cell growth, specialization, and survival so that your body and your cells normally proliferate. These are the factors that help do that. Growth factors along with the receptors, the kinase proteins, and the gene assembly. However, in cancer, there's an alteration of three types of growth signals. There's extracellular growth signals, so you're not really getting the growth factor to bind to the growth factor receptor. And the three ways in which that happens is autocrine, heterotypic, and paracrine. The other issue that happens in cancer is that there's alteration of the receptors. So either the receptor is overexpressed, simple examples are HER2/neu in breast cancer, or you could have a growth factor mediated ligand independent pathway. The third mechanism which sustains proliferative signaling is a complex pathway. It's an intracellular pathway of proteins. One of the common intracellular pathways is the RAF MAP kinase pathway. About 25% of all cancers in the human body, in terms of solid cancers, express this pathway. And the negative feedback is impaired, as you can see in the image in the middle. The pathway essentially promotes proliferation and sustains survival of a cancer patient. So when you talk about proliferative signaling, in in terms of the hallmark of cancer, this is how a normal and a cancerous cell works. Now, all of you, even in your graduate and postgraduate training, would have come across tumor suppressor genes. The two that we typically encounter the most often during our discussions is PRB, and it becomes active when it's dephosphorylated, and you can see the mechanism at the top right. If it's dephosphorylated, it gets active, and of course, it ends up being a tumor suppressor gene for the most part. However, if it's not dephosphorylated, then the issue is the inactivation of this tumor suppressor gene happens, thereby proliferating cancer. The p53 gene, of course, is termed as the guardian of the genome. Whenever there is DNA damage and chromosomal abnormalities, p53 gets inactivated. And as you know, in terms of head neck, me being a head neck surgeon, that's one of the commonest expressions. A DNA damage of p53, thereby resulting in loss of expression, thereby sustaining the other hallmarks of cancer and causing genetic instability, which we'll talk about later. But in terms of growth suppressor genes, the third is emerging a lot of meaningful data in terms of TGF-beta, the transforming growth factor, and typically a TGF-beta mutation promotes the phosphorylation of PRB, and which is why it causes the CMYC gene amplification. So the normal pathway of the retinoblastoma gene in terms of causing dephosphorylation does not act. A mutation also happens in an interacting domain, and there is viral oncoprotein-induced PRB dysfunction, and eventually there's loss of contact inhibition. All these mechanisms eventually result in no inhibitory growth signaling, thereby inactivation of the regular tumor suppressor genes that we encounter eventually results in cancer. Now, there is a mechanism of programmed cell death in our body. The programmed cell death does not happen when there is abnormal proliferation, but the mechanism of apoptosis has to be turned down. It needs to be inhibited for something to happen. This is a simple slide which shows the difference between apoptosis and necrosis. And like I said, I'll be glad to share the presentation, but broadly speaking, these are two very different pathways. Apoptosis essentially is a programmed cell death, and there are multiple anti-apoptotic genes and pro-apoptotic genes, and wherein a viable cell and a cancerous cell typically behaves, as you see in the graphic on the left. On the right, there's caspase activation, and as you would be knowing, caspases typically are executional caspases, which result in apoptosis or a programmed cell death. But any of these anti-apoptotic genes will typically, the balance is disrupted in cancer, in the intrinsic as well as the extrinsic pathway, as a result of which you eventually end up having a loss or a dysregulation of apoptosis. Normally, an inhibition of this programmed cell death will result from a combination of other hallmarks as well. As you can see over here, the patients will have a mutated or a missing p53. As you would know, the E6 protein inactivates p53 and the E7 protein inactivates PRB. Therein, these pathways of tumor suppression get inactivated. Along with that, the mutation of specific genes and the downregulation of apoptosis typically ends up causing a problem wherein you can see this cliff phenomenon. A chemo which goes to a primed cell will cause apoptosis or cause it to dysregulate. An unprimed cell will typically not cause apoptosis. But if you use a combination of targeted therapy as well as chemotherapy, you can typically reverse this cascade. Extremely important lines in the middle of the presentation. The therapeutic index for conventional chemotherapy relies on the increased sensitivity to apoptosis in cancer cells. Though cancer cells may select for evasion of apoptosis, they cannot select for resistance that they are yet to encounter, such as those provoked by chemotherapy. Therein, this forms one of the mechanisms for chemotherapy-naive tumors, usually being more responsive as opposed to post-chemotherapy or non-naive tumors. Along with that, the autophagy and the necrosis typically exacerbates that. Therein, there is an inhibition of apoptosis, causing the problem of the hallmark, which essentially indicates cancer growth. The fourth mechanism is a cancer cell typically replicates irreversibly or in an immortal fashion. There is something called the Hayflick limit. As you can see, the number of growth and division cycles of a particular cell are fixed. Usually, a cell would not divide more than 60 times. The number of divisions is determined by telomeres, which is, as the name would indicate, something at the end of a particular chromosome sequence. The telomerase activity is normally low. There are some exceptions of rapidly proliferating non-cancer cells like stem cells and fetal cells. These progenitors typically need to divide more than normal for obvious reasons, which is why the telomerase activity is high in these normal variants. Also, it's important to know that there are two terms called senescence and crisis, and these are normal terms. A crisis indicates a karyotypic disarray, which may or may not be associated with cancer, which results in cell death. And senescence means a cell is alive but cannot grow or divide. Typically, senescence would be concordant with the term that we use as aging. However, what happens in cancer? These two mechanisms are evaded. There is upregulated production of telomeres. As a result, telomerase gets produced more. Therein, the telomerase reverse transcriptase or the TERT mutation in glioblastomas is a classic example. Sometimes, in a significant proportion of human cancers, there might be a lengthening of telomeres which swaps around the telomeres and lengthens them. As a result, these cells get replicative immortality. The processes of senescence and crisis and normal aging of the cell does not happen, especially in that subpopulation of cells which have other hallmarks also working. We've talked about 4 now, and it's important to know that angiogenesis is an extremely important hallmark which was elucidated in published literature about 20 to 30 years back. In a normal cell, there are 2 mechanisms you can see in the image on the left as well as the text on the left, vasculogenesis as well as angiogenesis, and these 2 terms are complementary but they are distinct from each other. Whenever vasculogenesis doesn't need to happen, there's a natural switch off that happens. However, in a cancer cell, there's sustained angiogenesis, and we'll talk about the markers that do that. During your surgeries, you would have seen neovascularization around the tumor, typically manifesting in these fashions. There's a lot of capillaries on top. There's a lot of ectasia and convolution of the vessels on top of the tumor. The vessels are distorted and large. There's ectasia. They are thin-walled. The blood flow looks erratic. Tackling the tumor capsule compared to normal tissue typically starts off bleeding or macro hemorrhaging. The vessels are more leaky, and there are abnormal levels of endothelial cell proliferation and apoptosis. Stick with the last line here. In terms of endothelial cell proliferation, you need to know that the term of angiogenesis has some stimulators and some inhibitors. The stimulators are listed on the left, the VEGF, the PDGF, and the FGF, along with some interleukins and tumor necrosis factor. On the right, you have inhibitors of angiogenesis, and this is this balance or the balance seesaw mechanism that helps us manage a normal balance between abnormal angiogenesis and a normal angiogenesis. However, in tumors, there's something called angiogenic switch. And this was again described by one of the authors of the Hallmarks paper, Dr. Hanahan, in which there is a macroscopic conversion within the tumor cycle. Tumor cycle is something which we've already talked about. There is the G1, the G2 interface, the S cycle, and the M phase, and all of you are aware of that, of course. There is upregulation of genes. This combined with mutation of the tumor suppressor genes as well as proteolytic enzymes cause angiogenesis. And occupies a VEGF receptor. The production of PDGF is stimulated. So this is step number 1, leads to step number 2. The PDGF comes into the extracellular space and attaches to a PDGF receptor on the pericyte. The pericyte cell supports blood vessels. Essentially, it's a support mechanism for newly proliferative vessels. And this typically results in more stimulation and proliferation of abnormal vessels. So the VEGF, the PDGF, the FGF, and the pericytes and the cells along with are typically something that cause tumor proliferation. And this is the angiogenic switch, which we talked about, which results in a small avascular tumor, which might have been enough for our immunogenic pathway, now suddenly becoming a large tumor with potential metastasis. Speaking about invasion and metastasis, this is our sixth hallmark and the last of the initial hallmarks, in which it's important to understand that there are two types of cells in tumor tissue, the epithelial and the mesenchymal. Look at the arrow indicating EMT. That essentially means epithelial mesenchymal transformation. So epithelial cells which are adhered to each other transition very often, even in normal tissue, to mesenchymal cells where there's loss of cell addition. But the mechanism or the balance between the EMT is still not completely disrupted. This is helped by immunoglobulins and E-cadherins. Normally, epithelial cells and mesenchymal cells have alternating levels of E-cadherin and N-cadherin, which help maintain this homeostasis. However, when there is a carcinoma in situ, now we're talking about cancer that has already started, and we're talking about how it invades and metastasizes. It's important to know that this hallmark of cancer is actually specific to malignant neoplasms. The first 5 hallmarks that we discussed don't apply necessarily to malignant cancers. The first 5 are also applicable to benign tumor proliferations. But this is what makes cancer deadly. If there's a carcinoma in situ at the basement membrane, the loss of cell addition results in progression and thereby results in invasive carcinoma, which essentially means a breakdown of the basement membrane. The EMT, or the epithelial mesenchymal transformation, typically results in mesenchymal cells going past the basement membrane and causing invasion, as you can see. These invaded cells in the extracellular matrix eventually intravasate into 2 areas. Either they go lymphatic or they go into the bloodstream. If they go into the bloodstream, the next step is transit, step number 3 listed on the left, and therein they are transported through the circulation where they eventually extravasate and colonize, causing micrometastasis, which eventually results in macrometastasis. This is how tumor typically metastasizes. The pathway of invasion precedes the metastasis and the involvement of carcinoma in situ, or the first hallmarks causing carcinoma in situ, precede the invasive process. So invasion and metastasis typically forms the last step in terms of progression of cancer at a molecular or a cellular level. Subsequent to the 6 hallmarks, there was a lot of criticism in terms of whether or not they truly explained the pathway, the angiogenesis, the cellular mechanisms of cancer. A lot of literature developed between 2001 and 2011, and what we know now is an enhanced understanding of the hallmarks of cancer. 10 years after publishing the initial paper, the same 2 authors came back and presented the emerging hallmarks, which we, for the most part, know form the current basis of our understanding of genetic therapy and immune therapy in cancer. So past the initial hallmarks, there's genomic instability and mutation. The medical world has known for at least 15 years now that genetic mediated alterations of cause cancers typically. So the genome instabilities need to be better defined. This is what subsequent papers have tried to define. DNA damage or instability typically would result in genome instability, which is classified or further subclassified into multiple types, as you can see. In addition to that, tumor-associated macrophages, which are essentially transformed monocytes, the mechanisms are also well understood now. In terms of monocytes differentiating into TAMs once they're inside tumor, the tumor is already hypoxic. Hypoxic areas will release more vascular endothelial growth factor. The TAMs will release more VEGF, so there is a feed-forward loop or a positive feedback mechanism that results in growth of these tumors. Also, there is a dysregulation of the energy metabolism. Look at the graphic at the bottom right. Normally, glucose through intermediate process of metabolism gets transformed into pyruvate, and pyruvate therein through the respiratory process does carbon dioxide. However, anaerobic glycolysis in cancer as well as the aerobic glycolysis pathways typically result in the production of more lactic acid, which means less ATP. Therein, the metabolism is altered in the graphic that you see at the top right, where the growth and survival receptor is typically promoting a normal pathway. But remember the Warburg phenomenon? This is something that you probably get in your exams. Even in the presence of oxygen, you switch to anaerobic glycolysis, which is faster than the normal respiration, and lactates are precursors for various molecules required by rapidly dividing cells. And as we've discussed, cells typically rapidly divide, usually in a cancer environment, barring some physiological phenomenon that we discussed. It is this realized for the immune system failing when we typically look at cancers in general. So the normal pathways of work, which is listed on the text on the left, are immune surveillance and immunoediting. Our system naturally filters out certain cells which are potential precursors to premalignant lesions or even cancers. The cells that are involved in the immune pathways are the CD8 cytotoxic T cells, the CD4 helper T cells, and the natural killer cell. Whenever you have an immunodeficiency, either of one type or of multiple types, it makes the organism more susceptible to cancer. Let's move to the graphic on the right. So on the top, you have typical anti-tumor immunity where there is T cell recognition. However, when there is evasion of the immune response by tumors, there is lack of T cell recognition. As a result, there is a failure to produce tumor antigen, which would typically have taken care of the precursor tumor, and there are mutations in the MHC genes. In addition to that, what follows is the production of immunosuppressive proteins, which are essentially cytokines, and they inhibit the T cell activation. So not only is the T cell not getting recognized, it's also not getting activated, it's not binding to the receptors, and you have dysregulation of the immune pathway. Last slide on this. It's important to understand the tumor microenvironment when you talk about stem cells in terms of our understanding of the pathogenesis with regard to the same, and also with regard to the stem cells having a role in current cancer systemic therapy. The microenvironment is a homogeneous mix, as you can see on the top right, of cancer-associated fibroblasts, the stem cells, the immune inflammatory cells, the endothelial cells in the pericytes. A lot of them have a role in the mechanisms of tumorigenesis, as you see, in terms of angiogenesis as well as dysregulation. So when the core of the microenvironment typically gets dysregulated, the next step is invasive tumor microenvironment that further leads into metastasis in terms of the mechanism that we already discussed. Stem cells were first described about 16 years back. They've been identified in hematological malignancies, breast cancers, and PNETs. The cancer cells are more resistant, the stem cells are more resistant to therapeutic killing. As a result, it's a double-edged sword. Altered stem cells are used for stem cell therapy in a select subgroup of tumors, but at the same time, the stem cells are essentially progenitors that will typically result in more proliferation of cancer. So, when you look at the future, you want to look at your understanding of the hallmarks, all 10 of them, to help develop targets. When you develop specific targets, you get a potential cure for cancers. However, there are escape mechanisms. So it's important to know that when you have mechanism-directed therapy, this slide is extremely important in understanding the hallmarks and what mechanisms are going to be used to counter all of them. So if there is proliferative signaling, an EGFR inhibitor like cetuximab would typically have benefit in that regard. Similarly, certain anti-inflammatory drugs suspend or decrease tumor-promoting inflammation, which is why there's a role of COX-2 inhibitors in the same. VEGF inhibitors, like a lot of tyrosine kinase inhibitors that you see, reduce angiogenesis, as you can see as you look around the circle. Similarly, glycolysis inhibitors deregulate cellular energetics. So when you look at a tumor and you have to decide systemic therapy, or your colleagues have to decide systemic therapy, you want to look at a combination of the hallmarks, and this is what explains the rationale of combining cancer systemic therapy also. Combining MABs with cytotoxics, combining potential immunotherapy to avoid immune dysregulation, as we've just talked about, along with cytotoxics, thereby maintaining a balance between outcome and toxicities. So I believe the importance of understanding the hallmarks is paramount when we talk about understanding cancer in general at a cellular and a molecular level. Moving to the second part of our presentation, we've developed an understanding of the hallmarks, and it's important to know that whenever you understand the mechanisms of cancer, you know how to better investigate them and better tackle them. One of the three chief modalities of management of cancers, in addition to systemic therapy and radiation therapy, is what all of you practice routinely, surgery for cancer. It's interesting that surgery for cancer has its origins more than 4,500 years back. The papyrus on the right side, this is something I got off a book by Siddharth Mukherjee. There is the first medical description of cancer dates back to 2500 BC. And that papyrus is currently something that you can refer to as the oldest reference for surgery for cancer. What also mirrored the importance of surgical oncology was the development of two practices, anesthesia and asepsis. Once those practices developed, surgical oncologists, even as far as 200 years back, were able to give their surgical expertise safely to the patient in an aseptic environment. Because prior to this, sepsis and anesthesia-related complications used to result in deaths in most of these patients. Following this, a lot of pioneering surgeons took the lead, and I've only listed a few, of course. There's hundreds of them, and just discussing the history of surgery for cancer would take up hours altogether. But these are a few that are listed, and you'd be aware of all of them, and how Billroth, Halstead, Young, Wertheim, Miles and Grant influenced current surgical oncology practice is there for all of you to know. It's important to know our roots in terms of understanding where surgical oncology came from. These questions are very thought-provoking questions that are borrowed from the Tata EBM. We've had one perioperative anesthesia care EBM, that's an evidence-based management program. For those of you who are not aware, I strongly recommend attending those. They always change topics every year. When you look at anesthesia for oncologic surgery, there are guidelines for perioperative care, and most of these topics have not been settled in literature yet. There are issues with regard to perioperative care, and there are guidelines which are not only region specific, they are also specific to every particular patient. One patient might not respond the way you want to a particular therapeutic or an investigative intervention. In terms of perioperative care, you want to really balance your resources with what you offer the patient in terms of investigative protocols. In our country, compliance is a big issue. We did a compliance study on oral cancer presented at the Academy meeting in the US in 2019, looked at a subset of more than 500 oral cancer patients, and overall compliance to treatment is 60%. So you have to be very, very judicious in terms of recommending the right investigation protocol to your patients. And these guidelines or these questions will help you decide what is the appropriate institutional protocol for your group. When you take up these patients, and we just have a couple of slides of general considerations because we were asked not to make it site-specific. I think this is probably the only site non-specific talk in the entire series that is planned. You want to determine the operative risk, and there are multiple objective tools that will help you do that. Most of your institutions follow the ASA, but I would recommend, especially for youngsters like the attendees of this seminar, to look at other tools as well. We've looked at the RCRI. A lot of cardiologists like that. It's the Lees Index, and typically looks at cardiac risk with regard to potential dysfunction of other organ systems. The American College of Surgeons had a non-surgical quality improvement program, the NSQIP. This is currently suspended, but we used it for about 3 years, and we found it not necessarily to correlate with the Indian patient. It's important to know that all these risk indices are developed with an understanding or with the aim of making sure that we know how our patients are going to do from a particular surgery. However, sometimes they might not extrapolate to a different geographic or socio-economic environment. At the bottom left, this is an interesting review article from 2019 that I would recommend reading. A few others, which are either region specific or otherwise, have been listed over here. The importance of intraoperative indicators cannot be undermined. During the surgery, something as simple as your surgical safety checklist will impact outcomes. On the right, at the top, you see the classic ASA staging. And at the bottom, you see a paper which looked at about 100,000 surgeries and a 7-day operative mortality as a result of the same. And therein lies the basic philosophy of current educational training. Older patients, you have to be a little more careful about. A higher ASA grade, especially emergency, is something you need to be concerned about. A major surgery, administration of more intravenous fluid, all of those things are typically associated with potentially an adverse outcome, which is why we like to be expeditious with our surgeries. We want to preoperatively optimize our patients, and we want to make sure we minimize the operative risk by doing some degree of preoperative optimization. Broadly speaking about the role of surgery in cancer, surgery in cancer can be prophylactic, as you can see at the right. Borrowing from my field of work, medullary thyroid carcinoma, someone who has a red proto-oncogene mutation, especially one of the high-risk kinds, will typically require all the family members to be screened for the same mutation. And typically you find C-cell hyperplasia in the specimen for those who are mutation positive. So those are recommended a thyroidectomy. Familial breast cancer is a classic example. A lot of celebrities, by virtue of their personal experience, have really popularized this in terms of getting a mastectomy for BRCA positive. But again, it's not my domain. But again, prophylactic surgery is something we need to focus on. Diagnostic surgery, and this is something we do every day. Obtaining the right material, representative tissue, guided by our imaging and our scintigraphic colleagues to be able to make sure that we are able to get the correct diagnosis through surgery. So the role of a surgeon has evolved over time. A lot of tumors are now coming under the ambit of non-surgical organ preservation. That being said, we will always have a role in terms of managing our patients. Of course, coming to the crux, which is therapeutic surgery, the best case scenario is the one on the top, where you can get your primary resected. You can consider local therapy like HIPEC or any other therapy that you're going to do intraoperatively. And of course, there are going to be adjuvant considerations. The primary goal of this particular surgery is definitive. Cytoreductive surgery, again, a lot of data now, does not have a role in head neck, but of course, our surgical oncology colleagues all know cytoreduction, especially when done appropriately and in the indicated subsets, has survival benefits in conjunction with systemic therapy. For metastatic disease, we operate in very specific considerations and select individuals. We operate typically on solitary metastasis with a long disease-free interval and a potentially low morbidity of resection. This would typically apply to an isolated metastasis with a long DFS in between, and this does have evidence of improved progression-free survival. Oncologic emergencies, to put it simply, would be something that would necessitate airway control, nutrition control, a perforated bowel, or similar emergencies that you have to take up. Surgical palliation is extremely important, again, to restore airway, to take care of any hemorrhagic sequelae. And of course, the last part, which is extremely important, is part of current day practice in all of our centers, is reconstruction and rehabilitation, and that's important. Just DeVita prefers classifying them in such a form, so I thought this would be an interesting slide for you to see and review. We talked about perioperative outcomes, and it's important to know that perioperative outcomes are largely dictated in our country by one single factor, which is nutrition. So moving to the last 10 minutes, I have a dysphagia aspiration section as well, but I think with the permission of the moderators, I'll probably wind it up in about 5 to 8 minutes. Malnutrition affects a large proportion of patients with cancer. We know that in India, even more so. And head and neck is typically something that we see a lot of in terms of malnutrition causing adverse sequelae. What's important for all of our colleagues is that malnutrition will cause impaired or adverse outcomes for all modalities of treatment, surgery, chemotherapy, as well as radiation. And there's multiple data that supports that. Whenever there are factors that increase risk of malnutrition, it's important to preemptively diagnose them and optimize them thereby. And typically, the consequences with regard to modality-specific consequences of malnutrition are also listed for all of us to see. And this is something that might seem like preaching to the choir, but this is something we encounter every day. And sometimes post-emptively and sometimes preemptively, we are able to assess that. So when you assess nutritional status, you need simple screening tools, especially in our clinics where we see a large proportion of patients. There are screening tools which are not just physician administered or healthcare professional administered, they are patient guided also. We'll talk about 2 or 3 of them. There's a simple tool called the MUST, the Malnutrition Universal Screening Tool, and it looks at anthropometrics, nutrition-related problems, and feeding issues. There's a simple score range, and you can use it for nutritional assessment in your patients. Something a little more detailed, this is what our dietary professionals now do at our institution, an SGA for everyone, which helps you classify the malnutrition and thereby institute the appropriate therapy with regard to that. We won't focus too much on nutritional therapies for interest of time and to allow questions. There is also patient-generated subjective global assessment in which a patient can actually rate their own status. And we've started considering that at our current institution. Of course, it's going to be limited by socioeconomic and educational status, but patient-generated or patient-reported outcomes always have a caveat, and this, of course, suffers from the same. So currently, we are sticking to our SGA, which is administered by dietary professionals and ratified by our physicians. So when you want to give therapy, nutritional therapy in cancer, you want to restore, replete, as well as maintain quality of life. And this slide is important because it just boils down everything in the space of 6 words. You screen first, you recognize, you treat. If you're going to treat enterally, orally, or parenterally, it's up to you, but you keep on monitoring and reviewing. And there's multiple ways or portals through which you can do, as you can see in the picture on the right. Whenever you have patients diagnosed with cancer, we talked about nutritional screening being important, but patients with at risk of malnutrition will require some clinical nutrition tool and evaluation would be required. Patients who are unable to take anything, enteral nutrition must be started and screening should be performed, and these patients are usually bad candidates if you take them up right away for surgery. When you talk about cancer-specific nutrition, again, this is controversial, but a ratio of omega-6 to omega-3 fatty acids or EPA is fraught with a lot of conflicting literature, and I would recommend if you've developed an institutional specific protocol in collaboration with your dietary professionals, that's probably the way to go. But what's important, again, we're talking about SPEN here. You do want to improve outcomes of surgery and enteral nutrition, which in GI surgery should be distal to the anastomosis. And there's a lot of strength of evidence in these recommendations. When you talk about building up, protein is the essential component that you're looking at. And there's so many proteins in our body which typically require repletion. But remember, energy provision is not the function of protein. That's typically carbohydrates, which is why a lot of guidelines, including ERAs, have focused on that. Essentially, the negative energy balance is repleted by carbohydrates and a negative nitrogen balance is repleted by proteins. And in the interest of time, we'll keep on moving forward to make sure that we understand a brief part of the process and thereby are able to apply whatever nutritional screening or nutritional intervention guidelines we think. SPEN is one, advocates tube feeding, a whole protein formula, especially the patients who have severe nutritional risk. Some cases are listed over here, patients who are undergoing a Whipple's, an esophagogastrectomy. In the head neck cancer subset, laryngectomy, more so a pharyngectomy, would typically already have an altered swallowing apparatus neurogenically, mechanically, or obstructively. And these patients will come to you in a severely nutritional depleted state. And at this point of time, you want to intervene and you want to make sure that you replete them first and then move forward accordingly. The role of EPA, again, I will not talk too much about, but I'll end with this study which focuses on nutritional supplementation in cancer surgery. And you're looking at supplemented patients doing significantly better compared to control patients. Bottom line being, if you have a patient who is grade B or C on an SGA, is moderately or severely malnourished, you want to correct that first, utilizing whatever interventional tool you think is important, that you're familiar with, that your colleagues and your teachers have been implementing over time. Don't change your winning formula. Make sure that you use it to the best of your ability and optimize the outcomes of these patients. So I'll stop here, but I hope I've been able to give some perspectives in terms of cancer hallmarks, understanding the pathogenesis, moving forward, talking about some basic principles of surgical oncology and how we make these patients candidates for a particular therapeutic intervention, and finally talking about nutrition only partially, because we can't talk about nutrition without talking about the sequelae of malnutrition. We weren't able to talk about dysphagia and aspiration, but like I said, I'll be glad to share the presentation with them. Thank you for your attention.
Dr. Shamit, fantastic talk. Unbelievable how you did it. It would take phenomenal time to do such a talk. It's very easy to do a subject-specific talk, and the way you covered basics to nutrition, unbelievable. Superb. I can just only imagine the effort that must have gone to really prepare and put it. Nobody could have done. Now I really know why Kaustubh says, Sachin Tendulkar, Virat Kohli of Onco. Superb. Awesome. Thank you very much. And I'll before Kaustubh takes over, there are a lot of questions in the chat box and Q&A. You can open and answer, but superb. Hats off to you. Congratulations. Thank you.
Thank you.
Kaustubh bhai.
Thank you, Shamit. Yeah, thank you, Shamit. It was wonderful and very exhaustive, detailed, basic oncology, and I'm sure the DNB candidates would be very happy to go on and see this lecture on the website again and again, so that they can consolidate their knowledge. There are some questions. Shamit,
Yes,
Dr. Abhishek Verma asked that can you enlist some resources where we can find guidelines for pre-operative optimization specific for each system of cancer?
So that's a great question. I'll be very brief because the moderators, will want them to expound on their decades of experience in the field. But broadly speaking, ERAS is a great guideline, SPEN guidelines for nutritional optimization. We're only talking nutrition here. Nutritional optimization, SPEN is a good guideline, ERAS is a good guideline. In 2015, if I remember correctly, my prior institution at UC Davis developed a protocol of ERAS for head and neck. So this answers part of the question that has been asked by Dr. Verma. There are specific tools. It was initially developed for gastrointestinal and hepatobiliary surgery, but now it's been extrapolated all over. My suggestion would be to go to a good index database and try to search for any meta-analysis which deals with preoperative nutritional optimization in cancer. In terms of other optimization, nutrition is a monkey in the room. But if you talk about thromboembolic prophylaxis and everything, the guidelines are all there, and I'll be glad to share the PDFs with the NB.
Okay. Som, you would like to comment on this?
No, I entirely agree with Shamit. You can go to NCare Society from Sweden, and these PDFs are fantastically available. Even though, as Shamit told, they concentrate on ERAS, but their pre, intra, and post covers almost pretty much all the algorithm that needs to be followed. Also, just when Shamit was speaking, I just remember, I would request all the students, if possible, to have a subscription or an institutional subscription to uptodate.com. As you say, if you have a paid version and if you just type in, you will get all these PDFs very easily there.
Okay. I can't find any more questions.
No, Monica has asked, sir, can you please guide us, for us, surgical oncology, how do we do head and neck MCH oncology?
I think Dr. Kaustubh is very well placed. He's spearheaded an initiative that we've been very fortunate to be part of. But the question with regard to MCH head and neck oncology is something I can try to answer, but I would really want him to end with a message to all the potential trainees, even those who are already pursuing DNB. Sir, MCH head and neck oncology was started, to the best of my knowledge, the first students entered in 2013 at 4 institutions, 2 initially and then 4. So all of them are eligible to ENT residence. These would be the 4 index institutions were Tata Memorial Hospital, Kidwai Institute, Amrita Institute, and AIIMS. Following that, the initiative was expanded to include a few more AIIMS, and now currently the initiative is in its third phase, where they are looking at incorporating MCH in head and neck oncology in at least 20 to 30 centers across the country. We are halfway there. We presented at ASCO 2020, which was a virtual meeting on the South Asian Fellowship Initiatives that Dr. Kaustubh is the chairman of. So I would request sir to comment a little bit on that also.
Yeah, so there are structured fellowships for head and neck oncology also, which you can do after your surgical oncology degree. And there are short fellowships at head and neck state-of-art cancer centers, where you can train yourself for a year or so, where you can fine-tune your head and neck oncology skills. So these are the two options once you finish your MCH.
Good. Also, Kaustubh and Navneet Singh ji from National Board, whenever you have a classes for MCH head and neck, if they can also include the mailing list of MCH surgical onco students, because they learn a lot on head and almost 50-60% of surgical oncology training is also head and neck and breast. So I don't know, Kaustubh, the teaching program of head and neck, who is taking care? I know you liberally post it in all the WhatsApp group. Maybe also Navneet Singh ji try to include the surgical oncology DRNB student also in the mailing list of head and neck. Thank you.
Yeah.
And sir,
certainly do that.
To expand what Dr. Somashekar was saying, if the NBE is fine with that, they should also include the mailing list of the FNB head and neck oncology program residents, because
they are doing the same.
They are doing already. Great.
Thank you. I think, when it is very crisp and clear, Shamit, very little. Basically, I'll tell you something, because this is so vast and beautifully you covered. Students are wonderstruck. They thought that basic is something, but then you analyzed it in a vertical pillar. What I loved about your talk is, it is so vast. I was actually wondering when Kaustubh gave this topic, how will it be done? Because if it is given to me, it will take 3 months for me to analyze how I can do. Then I would request him, can you give me 4 talks, please? You beautifully divided into multiple verticals. And under the verticals, you gave the beautiful headings and the idea which students can actually, enhance. I always tell this to our students, they should never confuse at this level. We are not spoon feeding. They are not in nursery or first standard where we spoon feed. The purpose of us, all of us mentors at this moment, is to stimulate their brain, give an ideas, show the direction. These are where they have to walk that path and enhance on that, because it is so vast. And beautifully you put it, I really loved it. Maybe if it is okay with you, later you can make your PowerPoint a PDF so nobody can edit it, and I can put it in the DRNB WhatsApp and Telegram group for the benefit of students. It's an amazing talk.
Thank you.
Thank you very much, Kaustubh and Shamit. As I always say from DRNB, we are not in any position to give anything great to you. The blessings of the students to you and your family, and a warm regards from National Board is all we can give to you for accomplished, successful, very top oncosurgeons already. But that is something which carries to you and your family whole life. So thank you very much. Heartfelt thanks to both of you.
Thank you, Shamit. And thank you, Som.
Thank you. Over to you, Navneet Singh ji.
Yeah, thank you very much, trainees and faculty members, for joining the session. Thank you.
Bye-bye.